Hi, good evening, everyone. So, I welcome you all to Unacademy. So, before we start, let me tell you about the iconic subscription. You get Unacademy and Prep Ladder both at a very competitive price. And let us start with this session. We have a lot of features loaded in special classes, so do make use of them. Okay, so let us start with this session. The first question here is it for you. Tell me. All except are true for thyroglossal fistula. Okay, so I'm asking for all except are true. So that means the false statement. So let us talk about the concept of thyroglossal duct, cyst, and fistula. Let us try to understand. Okay. So when we talk about the thyroglossal duct, cyst, and fistula, but a question is a very easy question. If you see, this is not a congenital anomaly. Yeah. So thyroglossal fistula. Hi, hi everyone. Yeah, God bless you. So this is a thyroglossal fistula is always. Remember, thyroglossal fistula is always an acquired illness. Yeah. So it's always an acquired thing. Cyst is congenital. Cyst is congenital, but fistula is always acquired. So let us try to understand this concept. Now, so let us discuss few important points on this thyroglossal fistula and let us discuss this. So let us quickly go to the area. So if you talk about the important concepts of thyroglossal duct, cyst, and fistula, let us see that. So the topic that we are discussing is thyroglossal duct, cyst, and fistula. So duct, cyst, and fistula. Let us try to understand what is the reason behind this. This is a one simple straightforward reason. It is because of the persistent thyroglossal duct. And why it is persistent? Because of the failed regression. Why it is persistent? Because of the failed regression. So do you know that? Let me briefly tell you the concept of thyroglossal duct, how the thyroglossal duct is formed. So if you go to the embryology, this is the base of the tongue. So this is foramen cecum. So there is something which is known as foramen cecum, and this foramen cecum is having a medial enlarge. What do you mean by medial enlarge? The medial enlarge is actually the primitive medial embryonic part of the thyroid. Do you know that medial enlarge, it further enlarges into a diverticulum. So it enlarges into a bilobed diverticulum. So if you see, basically this medial enlarge, the medial enlarge will enlarge into a bilobed diverticulum. And do you know this bilobed diverticulum, this part of this bilobed diverticulum, this is what is known as thyroglossal duct. So actually, if you see, the medial part of the thyroid descends down with the help of this thyroglossal duct. Now, do you know at fifth week of life, actually the fusion of the medial enlarge with the lateral enlarge happens. So do you know the lateral and the medial, they will fuse with each other, and once the fusion happens, the regression of thyroglossal duct starts. So at fifth week of life, two crucial events are happening: the fusion of the medial enlarge with the lateral enlarge, and the second very important thing that we all know is the regression of the thyroglossal duct. Now try to understand, this regression should be completed by 8th week of life, and if it is if it is not done by the 8th week of life. So up to 8th week of life it continues and the regression is complete. But if failed regression at 8th week of life, this is going to be known as a persistent thyroglossal duct. So there are a lot of structures which are persistent. Why I'm discussing this thing? So that I can explain you the answer of the question which I have put up for you. So failed regression of thyroglossal duct by 8th week of life, leads to persistent thyroglossal duct. Now, why persistent thyroglossal duct forms a cyst? Do you know the thyroglossal duct is lined by something which is known as a columnar epithelium. So if you talk about the epithelium, so the thyroglossal duct is lined by columnar epithelium. So this is a duct and this duct is lined by columnar epithelium. Do you know what is so special about columnar epithelium? The columnar epithelium is going to produce the mucin. So there is presence of mucin secreting tubules, and this pseudostratified ciliated columnar epithelium will keep on secreting some level of mucin, and a time will come when this transforms into a cyst. So always remember that cyst is never present at the time of birth. Cyst develops around 2nd to 3rd decade. Is that clear or no? But actually the foundation stone of cyst is laid right after the birth. And do you know that therefore cyst is always congenital? This is always congenital. So if there is a persistent thyroglossal duct, it has to convert into a cyst. But now the cyst will eventually what? Rupture. The cyst will eventually rupture. Either it will rupture eventually, that is spontaneously, or the reason of this rupture could be iatrogenic. Now there are many cysts which should actually regress after their rupture, but this never happens with this. Why? Because this is active volcano like phenomena. It's not going to stop secreting the mucin. So remember, this is going to keep on secreting the things, and it never allows the healthy granulation tissue to develop over it. And over the time, what happens? There is epithelialization of the walls, and this results in formation of fistula. So one thing is clear, that cyst is congenital, but fistula is what? Acquired in nature. Is that clear or no? So this is very, very, very simple, very simple. So if you read this line that it is a congenital anomaly due to persistence of duct, this is absolutely wrong. So thyroglossal fistula is an acquired anomaly, whereas a cyst is a congenital anomaly. Is that clear or no? So everyone knows that the most common site, they are mostly located around the hyoid. So most common site is the infrahyoid region. So it's infrahyoid greater than suprahyoid, greater than juxtahyoid. Now you know, I know, everyone knows that if this is the scenario, this is the body of the hyoid and we have the cornu of the hyoid, and this is how the cyst is. So we will go for en bloc cystectomy. What is the management? The management, if you talk about the treatment, is en bloc cystectomy. Can you tell me what is the name of this surgery? En bloc cystectomy. This is what is known as cyst trunk. What do you mean by en bloc cystectomy? You are going to excise the cyst and the central part of the hyoid. So let us go to this question. Cyst trunk is the mainstay of the treatment. Yes, absolutely true. Infrahyoid location is absolutely true. Do you know that it is, if you see the development, why I ask students not to muck up, if you see the development, the thyroglossal duct is developing from the medial enlarge. And do you know medial enlarge is actually going to contribute to 2/3 of the thyroid. So the follicular cells, they develop from this medial enlarge only. the lateral enlarge actually contributes to the parafollicular cell. So bachcho, the thyroglossal duct cyst will also carry that same population of cells, and hence in future may have a risk of papillary carcinoma, maybe follicular carcinoma. Remember, all the carcinomas of thyroid can develop, but what can not develop from this? Answer is a MTC, because MTC, medullary thyroid cancer, is having a totally different. बच्चे en block का मतलब होता है whenever you are removing en block tumor, that means that tumor along with the block of the tissues which is around. So here if you see that the tumor is this is not a tumor, this is a tissue which is attached to the hyoid. So you are removing the target tissue and along with that the surrounding to which it is attached. So that is what is known as en block removal of cyst. So you are removing the cyst and along with that the block where it is present. That is what is en block cystectomy. So I hope this option is clear to everyone. All except MTC can occur. So let us quickly discuss one more important thing. All except are true regarding adenolymphoma of the salivary glands. Come on, tell me this question. All except are true regarding adenolymphoma of salivary glands. I hope this question is clear to everyone. Yeah. Let us talk about this adenolymphoma of the salivary gland and its an approach to this. Let us see. When we talk about adenolymphoma of the salivary glands, you have to understand that word lymphoma. The word lymphoma here is a what, students? Is a misnomer. So all except are true. Bache, Bhuvansari, try to understand. I'm asking the false one. Yeah, I'm asking. Very good, Hasti Gosep. Very good. So, Bache, the word lymphoma is a misnomer, because it has nothing to do with the lymphomatous component. Is that clear or no? So let us talk about something about adenolymphoma, then we'll come back to this question and solve it out. So let us see this. When you talk about adenolymphoma, what is this adenolymphoma also known as? What is another name for adenolymphoma? Answer is adenolymphoma is also known as Warthin's tumor. This is also known as Warthin's tumor. What is one more name for adenolymphoma? Yeah, this is also known as papillary cystadenolymphomatosis. So papillary cystadenolymphomatosis. Now try to understand what is this. Actually, this is a benign tumor. It is the second most common benign tumor of salivary glands. So benign salivary gland tumor. Point number one. Do you know? Oh, God bless you. Okay. No. Bache, I'm always there for Harsh. I'm always there for my students. God bless you. You can always come to this Unacademy platform. I take special classes here. No need to buy the subscription if you don't want. If you like, then only buy. And you can study a lot of things on this Plus platform as well as special platform and YouTube. Every day I'm taking some or the another platform I'm taking classes. So when you talk about this adenolymphoma or the Warthin's tumor, let us try to understand that these tumors are exclusive to parotid. They are exclusive to parotid, and this is very important. Now, do you know that majority of the salivary gland tumors are female predominant, but this is a male predominant tumor. So male predominant tumor, point number one, this is associated with the tail of the pancreas. I'm saying the tail of the parotid. So tail of the parotid, I hope you are knowing what is the tail of the parotid. But this location is what is known as the tail of the parotid. Lower pole of the superficial lobe is known as the tail of parotid. So tail of parotid is actually the most common side. The third is this is associated with 2-3 important things. What are they? It is associated with smoking. This is very important. And then it is also associated with the history of radiation. So if you carefully see, the patient will tell you that patient might have gone for any hair removal surgery or something like that, some treatments like that. So that is very important. So if you talk about the the concept of bilaterality. Salivary gland tumors are seldom bilateral, and Vardens is one amongst them which can be bilateral but not always. So remember, it's very simple, very simple. Less than 10 to 20% risk of bilaterality. Yeah, thank you, it's me. Yeah, but you, it's all your love and passion that is keeping me or driving me to teach you, and now growing to great heights. Now I've now managing two hospitals. I'm running a training institute for MD and for MS students, for residents, for MBBS, and just it's because of your love I'm doing that. Yeah, so God bless you, and don't worry, Dada is always there for you. Okay, so it's less than 10 to 20% of them are bilateral, and one more thing, they are mitochondria loaded. They are mitochondria loaded, you can say, tumors, and therefore on technetium 99 scan. So technetium 99 scan, if you talk about technetium 99 scan, the mitochondria will uptake this, and this will give you a hot spot. Let us talk about the treatment. I'll talk about the treatment later. First, I'll solve this MCQ, and then we'll discuss. So, exclusive to parotid, absolutely right. Associated with smoking, absolutely right. Hot spot on technetium 9, absolutely right. More than 40% are bilateral, absolutely wrong. So, C is the answer. Now, I'll discuss one more important thing with you. What is that? Let us discuss this. Approach to parotid mass. This is very important. Very important. So, approach to parotid mass. So, whenever you have a patient, like now, when we are deciding the treatment, we should not mug up. Yeah? Of course, Bache Harsh, you will become a bigger surgeon than me. Yeah, I am just an ordinary people. My all blessings with you. You'll all become. Once you have decided that you want to become a surgeon, no one can stop you. This is the instinct that we want in students. Yeah, you want to be a surgeon, just justify that thing only to you, nothing else. You'll start hard working. Yeah. So approach, whenever you have a parotid mass, the next thing is try to find out what is it. So for that, you need FNAC. Yeah, FNAC. Now the next thing is when you do FNAC, yeah, the next question that you are going to ask is whether you are dealing with a benign tumor or whether you are dealing with malignancy. Yeah. So when you talk about the benign tumor, the next thing that you want is where it is. Yeah, where it is. Now it could be actually along the superficial lobe, or it could be along the both lobe or deep lobes. So both lobe or deep lobe. So either it could be superficial lobe or it could be both lobes. You all will become surgeon. Yes, and this is not my swag. Actually, it's the branch. This branch is flamboyant, and whenever you become surgeon, you'll get that swag automatically attached to it. So I always tell students, you get respect in all the medical professions, in all the branches. Yeah, but actually respect with swag, this is the only branch. Yeah. So this like, so when you talk about the superficial lobe tumors, if it is benign, the next thing is you have two options. What are that? Remove the entire superficial lobe, This is what is known as superficial parotidectomy. Is that clear? No. So this is known as superficial parotidectomy. Next is bachcho, if you talk about, there's a one more logic, that instead of removing the entire superficial lobe, why don't you just remove the tumor? So wide local excision, that is what is known as a suprafacial parotidectomy. Now what is the importance of suprafacial parotidectomy? Students, in suprafacial parotidectomy, suppose if this is the tumor, I'm going to just remove this part. So I'm going to just remove the part which is required. Unnecessarily, I'm not going to search for the facial nerve, dissect of its branches, resulting in ultimately minimum neuropraxia, or you can do a neurectomy also during dissection. So suprafacial parotidectomy is defined as a wide local excision of the lower pole tumors, simply. Now, if it is a benign tumor involving both lobes or the deep lobe only, you're going to go for total parotidectomy. When you talk about total parotidectomy, students, this has to be what? Nerve conserving or nerve preserving. So it has to be nerve conserving. The next is when you talk about, but the margin is not an issue here. Let me tell you, when you're talking about benign tumors, when you talk about benign tumors, you know that this is the facial nerve which is going. Yeah. So Java, try to understand, this is the facial nerve which is going. So what we are going to do in this case, suppose if the tumor is here, we are going to remove the entire superficial lobe, exposing the nerve. So above the faciovenous plane of Patty, you will remove everything. So here, this is what is known as superficial parotidectomy. When you talk about suprafacial parotidectomy, you take a decent margin of 1 to 2 centimeter. This is 1 to 2 centimeter. Around that tumor, you'll do. Whenever you remember, students, that minimum tumor margins are for the reference for pathologists. For surgeons, whenever we do a wide local excision, we always accept 1 to 2 centimeter of margin of healthy tissue around the tumors. वो फिर pathologist will see the specimen and they say, okay, you have resected a right margin or no, because we are not having the microscopic vision, we are having a macroscopic vision. So whatever we see crude with our eyes, we take sufficient healthy margin around them. Now, when you talk about if it is a malignancy, you will have to go for radical parotidectomy. Harsh is answering, sir, I have not been able to study 12 to 14 hours a day, only 8 hours a day. I got 10 rank in. It's possible. But see, definitely, who says the human efficiency stops after 8 to 10 hours of efficient work? So don't worry that if you're not able to study 10 to 12 hours. It should be, you study 8 hours a day, but it should be absolute 8 hours. And take my words, if you're able to study absolute 8 hours per day, you're going to rock it. Agar absolute, don't think that this 8 hours should not include the recreation time and this and that distraction time. 8 solid hours is more than enough. So radical parotidectomy, when you talk about radical parotidectomy, the management is, what are you going to remove, students? You are going to remove the gland, you are going to remove the duct, you are going to remove the fat, you are going to remove the fascia, you are going to remove the lymph nodes, you are going to remove the muscle. What are the muscles that we remove? First of all, masseter. Why masseter? Because it is included in the same fascia, paroticomasseteric fascia. Another is buccinator, because you know that the duct pierces through this and opens into the oral cavity. So ये सारी निकालनी पड़ती है. And along with that, involved part of facial nerve. So involved part of facial nerve is also to be removed. So let us go to the next question. I hope this is clear, and randomly let us discuss a question. Chalo. So let me discuss this question. Dysphagia lusoria. This question is on dysphagia lusoria. This is a question on dysphagia lusoria. So dysphagia lusoria, what is the concept of dysphagia lusoria? Let us try to understand this. It's a very simple, straightforward thing. Let us try to understand it. Very good, very good, very good, very good, very good, very good. So let us see. It's a compression by aberrant, you can say, blood vessel, aberrant blood vessel. Very good. All of you have answered it rightly. So when we talk about dysphagia lusoria, forget everything. You have to understand that dysphagia lusoria, the concept is associated with abnormal right subclavian vein. Very good. Very good, Digit. So this is associated with aberrant. This is associated with aberrant right subclavian artery. Subclavian artery. Now, why this is aberrant right subclavian artery? Try to understand. This is right common carotid artery. Instead of it being a right. Yeah. I'll do motivational video. Because I'm not a big person that I'll motivate everyone. I'll just want to say one thing, that when one fine day all of you will be on the other side of the horizon. So stop taking stress. Do your best, perform your best, because under stress you always underperform. So don't think about anything. Maximum what has happened, you all have attained a minimum level of job security. So when you are thinking of broader perspective of doing a PG, that's an add-on jewel to your crown. You have already won that crown. So when you move out, actually you're talking to the near and dear ones who are always, you can say, under the peer pressure. You know, he has done this, he has done that. But if you move out, if you see the level of joblessness, if you see the level of job insecurity, then you'll feel proud that at least you have completed your MBBS. But you just continue the phase. This is going to continue for your life. Stop bothering, enjoy your life, prepare, you will win. Don't think, but say everyone will get a chance. When a moron like me can do it, you people are far more intelligent. So this is left common carotid artery, this is right common carotid artery, and this is left subclavian artery. Now sometimes what happens, there is an anomalous origin of right subclavian, either from the descending or from the what students, from the left subclavian artery. Now when this is going to happen, now right subclavian artery is saying I want to go back to the right side. Now how it will go? With the only place which is left, there is esophagus in the posterior mediastinum. There is no space left. The only space left is a prevertebral space. Yeah, prevertebral space. So what happens? This artery actually takes this course. Can you see? This artery takes this course and goes like this. Now, do you know this is artery? And this is artery is associated with what? This is pulsations. And if there are pulsations, what will happen, students? Come on. If there are pulsations, there will be indentation of the posterior wall of the what? Esophagus. So these arterial pulsations will actually cause indentation of the posterior wall. So arterial pulsations and therefore indentation of posterior wall of the esophagus. And since there is indentation of the posterior wall of esophagus, this is going to result in what? Dysphagia. So irritant, discordant movement of the esophageal wall, this is all going to result in dysphagia. The second thing is arteria lusoria. This is what is known as arteria lusoria. Arteria lusoria. Let's say arteria lusoria is also associated with one more thing. Yeah, one I have told you is dysphagia. One is non-recurrent right laryngeal nerve. So non-recurrent right laryngeal nerve, this is again a big task to counter during the thyroidectomy when you're not finding the nerve, and then the problem will start. So let us move to one more question. Let us discuss one more question. Chalo. Let us discuss this question. All except are true. All except are true for the wounds. Yeah. Class 2 wounds are surgically created. This is option 1. All except, you need to find the false one. Yeah. Class 3 wound is associated with spontaneous viscous perforation. Class 1 wounds are associated with no contamination, and all of them are true. Can you tell me what is the answer? Yeah. Yes. I'm still waiting for the right answer. I'm still waiting for the right. Come on, answer. Try. Awesome, David. Awesome. So David has answered it right. Let us see. बच्चे class 3 wounds. Okay, try to understand this. Class 3 wounds, they are associated with spontaneous viscous perforation. No, the spontaneous viscous perforation belong to class 4. Yeah, so this is very important, very important. So I'll clear all your doubts in this. Let us quickly discuss the concept of wounds. Let us quickly discuss the concept of wounds. When we talk about wounds, one very important thing is classification of wounds. So class 1, this is equal to clean wounds. Yeah, class 1 is equal to clean wound. And remember, what are the clean wounds? They are the wounds where there is no entry into GIT, GUT, respiratory tract. Example, if you're doing mastectomy, if you're doing thyroidectomy, they're all class 1 wounds. But say they are also the wound associated with no contamination. They are associated with no contamination. Now, Zaba, I'm going to remove your confusion. The word contamination is not infection. Contamination is mere presence of bacteria. And then the next is proliferation. And once there is proliferation and also the systemic, or you can say the release of the toxins produced by these bacteria, that is what is known as infection. So bache, class 1 wounds are clean wounds. Now one very important thing about them is, what is that? Despite the fact they are clean wounds, they also carry a risk of SSI. What is that risk? Students, 1 to 3%, generally some books says 1 to 5% also, 1 to 3% risk of SSI, surgical site infection. Then the next we have is class 2 wounds. What are class 2 wounds? They are actually defined as clean but contaminated. Why they are clean but contaminated? Because they are the one which are handling GIT, GUT and respiratory tract. So there is entry into GIT. You know, GIT, all the hollow lumens, they are in connection. All the hollow lumens of the body, they are in connection with the external world, and therefore contamination is there. Bacteria is always there. So there should be no spillage. So entry into GIT, GUT, respiratory tract. It's like you do cholecystectomy, class 2, you do hemicolectomy, class 2, you do radical cystectomy, class 2, you do nephrectomy, class 2. So they're all clean contaminated wounds, but without spillage, or minimum spillage, or minimum controlled spillage. So minimum controlled spillage. Is that clear or no? But so they also carry a risk of infection, and that is 2 to 9% SSI, surgical site infection. Now, do you know that we have class 3 wounds? What are class 3 wounds? They are the first category of wounds which can be associated without surgery also. If you see class 1 and class 2 wounds, they are exclusive with surgeries. They are exclusive with surgery. But class 3 and class 4 wounds, they can be created outside surgery. So all the fresh accidental wounds, they belong to this category. Point number 1. Second is, any patient where there is entry into GIT, GUT, respiratory tract with gross spillage. Is that clear or no? Like you were doing hemicolectomy, that was class 2. During hemicolectomy, if the accidental clamp got opened, there was swelling of the abdominal cavity with the stool. This is a class 3 now. Cholecystectomy is a class 2. During removal of gallbladder, there was perforation and there was leakage of infected bile into the abdomen. Again, it becomes a class 3 now. So gross spillage, a component of gross spillage should be there. Along with that, any patient where there is breach, or you can say gross breach of asepsis. What do you mean by gross breach of asepsis, students? Yeah, that means if you perform any surgery outside the operation theater, automatically that becomes a what? Gross breach of asepsis. Like The example of this, sometimes in trauma patients, you might need, because of a patient coming to you with a thoracic trauma with ventricular asystole, you need to open up the thorax and give a cardiac massage. So example is open cardiac massage. Open cardiac massage. So open cardiac massage in ER room. You may have taken antiseptic precautions or sterile precautions and sterile drapes, but since this OT is done outside the operation theater, so this is 3 to 13% risk of SSI. Are you getting this? And they are what? Contaminated wounds. They are classified as contaminated wounds. Then we have students class 4 wounds. Class 4. बच्चे hydrocele hernia surgery is a class 2 wound. Class 2 wound. During hernia, if there was opening up of, if you talk about hernia, you're reducing the cavity. If there was accidental damage to the bowel, suppose it's a case of hernia in glissade and there is a damage to the bowel, so what is that now? That is a class 3 now. Why? Because there's a spillage of content. So minimum class 2. Next, class 3. What is class 4 now? Class 4 wounds are the wounds which are dirty in character. Do you know, students, they have variable risk of SSI? Variable risk. The latest book says 13 to 30%. It can vary from 13 to 30% risk of SSI. What are they? They are all old, neglected, grossly contaminated wound, like necrotizing fasciitis. Yeah. So old, neglected, grossly contaminated wounds. What else apart from them can be classified or designated as class 4, students? Yeah. Class 4 dirty wounds, if you talk about, one is old, neglected, grossly contaminated. The second is spontaneous viscous perforation. Any case of spontaneous viscous perforation, spontaneous viscous perforation, peptic perforation, appendicular perforation, they're all belonging to this. So students, if you read this question, now you will have more confidence. Class 2 wounds are surgically created. Absolutely true. Class 1 wounds are associated with no contamination. Absolutely true. Class 3 wounds are associated with spontaneous viscous. No, iatrogenic I would have considered here. Amputation, but the indication of amputation is necrosis. Yeah, gangrene. So gangrene, necrosis, they all belong to class 4 now. Yeah, amputation is not done for a sterile, you can think. Is that clear or no? So amputation is a class 4 beta, minimum class 4. Yeah. Let us talk about this is wrong. So the answer for this is C. So now every day for next 6-7 days, I will be taking the fast track revision around 10-15. So every day, book your slot, spare some time, 10:50 p.m. Yes. And if you really like the class, do join Unacademy for the plus. Use the code Dr Dixit to get some extra discounts and offers. So do give your feedbacks, do recommend Unacademy to your friends, and till then, bye bye, stay safe.